evening, everyone. At the outset, my apologies, and thank you very much for waiting. I can understand this is a weekday, and tomorrow there are two conferences. Still, all senior people and colleagues have taken time out to attend this program. So I would like to welcome Dr. Prakash Chanwani sir, Dr. Sanjeev Sharma sir, and all the experienced and senior intervention cardiologists in the audience. So I think we should start a session. Should we wait for anybody else? I think we start. Okay. So I would like to invite Dr. Prakash Chanwani, Dr. Sanjeev Sharma sir, and Dr. Sanjog Kalra, who is not here, as chairperson. Is Dr. G.L. Sharma sir here? No. Okay. And Dr. Bambani also. Sanjeev sir? So I'm also going to introduce Dr. Sanjog Kalra. I think I'll introduce him once he's here. So we start with the first talk, and the talk is by Dr. Sanjeev Sharma sir on IVUS-based algorithmic approach to calcium management.
Good evening, everyone. First of all, I would like to appreciate efforts by Ravindra for having this calcified disease management symposium. As we are running late, so I would like to be a little brief. I will skip a few slides. For me, topic is IVUS-based algorithm approach for the calcium management. As we all know, severely calcified disease puts a challenge on your intervention. As the calcified lesion, they respond poorly to balloon angioplasty, and they are very difficult to dilate. You see the dog mourning while inflating balloon as a part of pre-dilatation, and at times it causes extensive dissection, proximally, distally, and the calcified lesion, sometimes it's very difficult to negotiate stent across it. And when we deploy the stent, it has under-expansion and malapposition also. And all these under-expansion and malapposition leads to stent thrombosis and also high risk of restenosis in the short as well as long term. So we need to address this calcified disease in a systematic way. And for that, the imaging is integral part. As we have two imaging modality, IVUS and the OCT. About the IVUS helps us in giving a clear information about the plaque morphology and how should we go ahead in the preparation of the vessel bed prior to putting a stent. On the left side, you can clearly see it's a soft plaque, fatty plaque, which can be easily managed with a simple pre-dilatation balloon and then go ahead with the stenting. For the fibrotic lesion, we need to have either a scoring balloon or cutting balloon to break the lesion and then go for the stenting for a good stent deployment. And when there is a calcified lesion with an arc more than 180 degree and the thickness is more than 0.5, then we need to update it by the plaque modification or ablation strategy like rotational atherectomy or orbital atherectomy. And if there's a deep calcium, then we need to have a shock wave to break it further prior to putting on the stent. Now, how do we classify the severity of calcification based on the angiogram and the IVUS? We say it's a mild calcification or a no calcification when on the fluoroscopic image, we don't see any calcium fluoroscopically. On the IVUS, we hardly see any calcium or there is less than 90 degree arc of calcium. And for moderate calcification, just before the injecting dye, we can visualize the calcium This is on the one side, just one side calcium. On the IVUS, we can have a 90 to 180 degree of arc of calcium. And for the severe calcification, we see a tram track like calcium. The two parallel lines of calcium as a tram track, we can clearly see in fluoroscopic images, and that can be confirmed by the IVUS as a more than 180 degree arc of calcium, 270 or 360 degree. And this calcium incidence, we from the literature is 6 to 20%, but everyone will be having an agreement that it's more almost 30% these days now in some of the cath labs. And angiographically, we can appreciate calcium in only 46% of the cases. And so we need to use more and more imaging just to have a clarity about the plaque morphology in terms of calcium. This is how we appreciate calcium on the intravascular ultrasound imaging. On IVUS, we can quantify calcium by seeing the arc. It can be one quadrant less than 90, if two quadrants is almost 180, 273 quadrant, and 360 is a napkin ring calcium when the whole circumference is occupied with the calcium. And calcium, we also classify by the location. Is it superficial? The superficial calcium is close to the lumen of the vessel, or it's a deep, it's more closer to the adventitia. And when we look at the arc of calcium, if it's a one quadrant, it's less than 90 degree, two quadrant is almost 180 degree, and if it's severe calcium, we find more than 270 degree arc of calcium. At times it's a napkin ring or 360 degree arc of calcium. So it's very important to assess how many quadrant has been occupied by the calcium arc. This is angiographically. On the first panel on the left side, you can see there is a tram track like calcium. Before injecting dye, you can see the calcium. On the middle panel, we can see in the mid LED, there is a calcium on the one side. So it's a moderate calcium. And on the third panel, the hardly visible calcium. So it's a none or mild calcium. This is fluoroscopically defining the calcium. Now coming to how we correlate angiographically calcium with the IVUS. This is the bar diagram which clearly tells us even with the mild or moderate calcium, the mild calcium is the yellow and moderate calcium is the blue and the green is the severe calcium. Even when the angiographic calcium is mild or moderate, we can clearly appreciate there can be 3 or 4 quadrant of calcium on the IVUS imaging. So we cannot rule out calcium just on the basis of angiographic appearance of mild to moderate calcium. We need to image it to have a clear picture of the calcium. And same thing on the right panel, we can see superficial calcium, how it correlates with the IVUS. At times we see a tram track like calcium, but on IVUS, there's hardly any calcium on the intima side. Either it's a none or the one quadrant of calcium is occupied. This is all because of the adventitious calcium. These lesions can be easily managed with a non-compliant balloon or the scoring balloon because there is no calcium in the intima or media. This is a study of stable angina patients, of 440 patients, how the angiography correlates with the IVUS or OCT calcium. This also endorses the same view that even if we find a mild to moderate calcium, on imaging we can have a 3 or 4 quadrant of calcium. So imaging is a must whenever we encounter challenge, like angiographically you see a calcium which is not much, but during pre-dilatation you see dog boning, so better you take out the balloon and do the imaging. Or in a first go also, in all the high volume center with the complex lesion dealing, we should go ahead with imaging first after putting a wire to have exact clarity about the extent of calcium and how best we can address that calcium. This is how we can define the calcium on IVUS. The thin calcium, which is quite smooth and hyperechoic rim, and beyond that we can see reverberations. These reverberations just give an appearance of stent-like. there's a calcium inside, and sometimes we see there is a stent. There was no history of prior PCI, but we can see reverberation effect of this ultrasound imaging. So these are thin cap calcium, and the other side there is an irregular surface with a thick calcium, in which we can see the echolucency beyond the calcium. And when we see here in the OCT imaging, there is a thin arc of calcium which correlates with the thin smooth calcium on the IVUS, and also there are reverberations on the two middle panels. On the right side, we can see a thick lesion with a echolucency, which we can clearly correlate with the OCT calcium. This is again, it's being confirmed like a thin calcium, almost 270 on the IVUS imaging, and along that you can see the reverberations. And this correlates with the OCT imaging of calcium. And on the right panel, there is a thick calcium with the echolucency beyond that. We cannot measure thickness of calcium on the basis of IVUS imaging. In the same panel, we can see the your OCT imaging. We can clearly make out the thickness of calcium. This is the only drawback of IVUS as compared to your OCT. We cannot judge the thickness of calcium, although we can see the arc of calcium, length of calcium, but we cannot judge the depth of calcium. This is again one of the study which has compared the angiography versus IVUS and OCT. Definitely, angiography detect the calcium in 40% of the cases, and the IVUS and OCT both, they detect the calcium between 75 to 80% of the cases. In this study of stable angina patients of 440 patients were the angiography, IVUS and OCT were compared, and we can clearly appreciate that angiography could detect in 40% of the cases, IVUS and OCT close to 70% cases. There are a few cases in which IVUS calcium was there, but the OCT didn't have any calcium. This they attribute to the superficial OCT plaque attenuation. These are the different parameters we assess on the IVUS. This is the first panel is the arc of calcium. Here it's almost 270 arc of calcium. And this is the middle panel is a reverberation. We see in a thin calcium, thin napkin-like calcium, and we can see the reverberation beyond that. This is calcified nodule on a 12 to 2 o'clock, and with the echolucency beyond that, because the ultrasound wave couldn't go beyond that. And on the bottom panel, there is a more than 5 millimeter length of calcium with a more than 270 arc. These are the few parameters: angle of calcium or arc of calcium, thickness of calcium, and this is how we calculate the calcium score. It's based on the OCT, but we can also use it for the IVUS. If angle is equal to less than 180 is a 0 point, more than 180 is a 2 points. The thickness of calcium is equal to less than 0.5 is 0, and more than 0.5 thickness is 1 point. Length of calcium is, if it's equal to less than 5, then it's 0 point, more than 5 is 1 point. And total score is 0 to 4. And out of these 4, if the score is 2 and more, we should go ahead with the plaque modification by rotablation or orbital atherectomy. So out of 0 to 4, 2 is the cutoff. 2 and more, go with the plaque modification. This is the same thing. And this is the algorithm. The de novo calcified lesion, I think the slide is a little less visible. And we need to assess the disease complexity. Whether it's a left main or three vessel disease with syntax score more than 22, and also the diabetes. If there is a syntax score is high, left main disease is there, then surgery is one of the options. If syntax score is less than 22 and this is not that complex, we can straight away go ahead with the PCI, and we detect the calcium, angiographic calcium. If it's mild, go ahead with the non-atherectomy strategy. If calcium is severe, go ahead with the rotablation or the orbital atherectomy. If it's a moderate, we can go ahead with the imaging. In the imaging, if we find a severe calcium, go ahead with the rotational atherectomy or the orbital atherectomy. If it's mild, we can go ahead with the cutting balloon, scoring balloon, or pre-reduction balloon. And this is a very important algorithm for the optimal management of calcified lesion. The lesion with a high calcium content on coronary angiogram, we just assess whether it's a balloon crossable lesion. If it's not crossable, then you go ahead with a microcatheter with a wire. If you can cross it, we can exchange with the rotawire and do a rotational atherectomy or orbital atherectomy. If it's not possible, then we can straight away go with the rotawire or the Viper wire. If we are able to cross, then go ahead with the atherectomy. If you cannot cross with the rotawire or Viper wire, use a laser. And following that, we can do a balloon dilatation and go ahead with the stenting. If it's suboptimal, we can still do a lithotripsy with a shock wave and then do a PCI. If the lesion is balloon crossable, then you dilate and then do the imaging and assess all the parameters. If the arc of calcium is more than 180 and the calcium length is more than 5 millimeter and the calcium thickness is more than 0.5, then go ahead with the plaque modification and assess whether it's a deep calcium or superficial. Superficial, go ahead with the rota or the orbital atherectomy. It's a deep calcium, then do a shock wave. If all those criteria are not met, then you can go ahead with the pre-dilatation balloons, either a simple NC balloon or the scoring balloon, and do a stanting. And following stent, if it's on imaging, it's a stent is well opposed, well expanded, it's a final outcome. If it's under expanded on the imaging or under deployed, then we can do a shock wave and optimize the result with a post-dilatation balloon. There are a few interesting cases which I would like to share quickly. 75 years old male, diabetic hypertensive for last 5 years, presented with the unstable angina, stable hemodynamics. ECG revealed T1 inversion precord leads. EF is 50% with the LED hypokinesia and fairly well controlled sugar. LV is normal. Now we can clearly see just before injecting dye, there's a long calcified lesion in the proximal to mid distal LED. And in the caudal view, there is a large nemus coming out of that area, and there is a plaque in the distal left main also, which is also having a little bit of calcium. Circumference is quite small and doesn't have any big area to supply. Right coronary has a calcium, but it's an intermediate lesion, 50%, in the proximal and the distal part. And the FFR for the RC was done, which was within normal limits, more than 0.8. So the plan was to go ahead with the PCI. So started with there was difficulty in passing the IVUS catheter. So straight away with the rota, crossing and exchanging your fine cross with the rota wire, and this is ablation by the 1.75 burr. And there was a lot of resistance in the proximal to mid part, and which was very well dilated with the gentle packing movement. And then subsequently the imaging was done. In this IVUS image, you can appreciate there is a plaque, there is calcium from 4 to 6 o'clock, and this is fibrotic. There is a calcified lesion from 9 to 4 o'clock. And then there's a branch. Here there's a calcium from 4 to 9 o'clock. Here you can see the knife-bending calcium, although it was after ablation with the rota ablation 1.75 burr. So it's a very well ablated, and the thickness of calcium. Now you can see the 360-degree arc of calcium in the proximal LAD. Here also, the reverberation artifact was also there, which we discussed. And this is the proximal part of the LED. And here is also calcium, and this is close to left main. There is calcium in the left main also from 11 to 1 o'clock, and left main is quite roomy, around 5 millimeter, and this is a normal left main. So after that, we had gone ahead with a scoring balloon to dilate it further, 3.5 millimeter scoring balloon at 16 to 20 atmosphere, right from the distal, mid, and proximal LED and the distal left main. And then 3 into 48 stent in the mid to distal part, and then 4 into 38 DS overlapping with the previous stent in the left main to LAD. And it was optimized with the 3.5 to 4 millimeter balloon in the proximal mid part, and the left main was optimized with 5 millimeter balloon. The post dilatation right from the distal mid LAD and the left main, and this is imaging post-stanting. It's a well deployed stent. You can see well expanded stent. There's a little bit of plaque burden from 4 to 9 o'clock. It was well opposed, well expanded, very good luminal gain. MSA was quite good, 7 to 9 millimeters square. And here you can see there's the calcium where it's a little under, which was further post dilated. And the left vein was optimized with a 5 millimeter balloon. And here you can see the very well deployed, very well opposed stent in the left main. This is the final angiographic result. And the REMUS, which was 50 to 60%, it remains so. So REMUS was kept provisional for this stent. The two overlapping stent from left main to LAD, well optimized. Second case is 59 years old male as a diabetic and unstable angina with a history of progressive effort angina for 5 months. ECG was within normal limits, LV was normal. And this you can clearly see the heavily calcified LAD right from proximal to mid-distal. And this is a very diffuse disease. And there are two big diagonals coming out of it. The diagonal 1 is 80 to 90%, and the diagonal 2 is also very tight, 90-95%, and the diagonals were also calcified. And LAD appears very diffuse disease, right from proximal to mid-distal. So caliber was not quite good. So these are the cases with the diabetes, with such a long diffuse disease, with the two big diagonals, and so it's a candidate for the surgery, but we refused for surgery. So he was taken up for the PCI, and this is again gone ahead with the fine cross, exchanging with rotawire, and this rotablation with 1.5 fiber. And there was a heavy chunk of calcium right from proximal mid to distal LAD. And this is I have a snapshot. You can see the napkining calcium in the proximal and mid part, 360-degree arc of calcium, 270-degree arc of calcium. And there was diffuse disease, a lot of plaque burden in the distal LAD. There was no disease-free area. You can see in this IVUS pullback image, there are a lot of plaque, fatty plaque in the distal LAD. And then coming to the proximal, the mid LAD, is a lot of calcium, either equidistant beyond that, and a heavy plaque burden. Now this is a 6 to 12 o'clock. This is 270-degree arc of calcium here, and there's a branch coming out of it, diagonal. Again, there is a heavy plaque burden, and the diagonal branch. And this is almost 180 degree. This is 270-degree arc of calcium. After plaque modification, rotaformal fiber, you can see your calcium thickness gets reduced, and the compliance is quite good. So you can break further with the scoring balloon or the non-compliant balloon very easily. Here also there is a 360-degree arc of calcium, and here in the almost close to the left main, there was a calcium. Now it's coming to the left main. Here also there is hardly any running zone in the proximal part of the LAD. So it was post rotablation with 1.5 fiber. It was dilated with 2.5 NC balloon, and then first stent 2.5 to 38 deployed in the mid to distal LAD. And then the diagonal 2, which was quite tight, was dilated with a 2 millimeter balloon. And subsequently one more overlapping stent in the proximal LAD, overlapping with the previous stent, 3 into 32. And then post-dilating in the distal part with a 2.75 millimeter balloon, and the proximal part with a 3.25 and 3.5 millimeter balloon, and then kissing of the diagonal 2 in LAD with a 3.25 in the LAD and 2 millimeter in the diagonal. So we kept the diagonal as a provisional, and if there is a compromise, we can do a provisional T, and that is proximality optimization. And this I have a snapshot, very well deployed stent throughout the length, right from the distal to the proximal LAD. This is I was pullback. I'll go a little quick. This is there are heavy plaque burden in the LAD. In spite of dilating very high pressures with 275 and 3 millimeter balloon, you can see there's a quite a plaque burden. But imaging really helps us in planning the plaque modification, what modality is best suited for the patient. If there's a arc of calcium is more than 270, if the thickness is more than 0.5 and the length is more than 5 millimeter, you can straight away go with the atherectomy followed by a scoring balloon or the NC balloon depending on the thickness of the plaque. And yeah, we can see there's a very well deployed stent right from the distal to the proximal part of the LED. And there was a little calcium ring in the distal left vein, although it was non-significant. This is the final result, which we can the final angiographic result. You can clearly see the very well deployed stent right from proximal to mid-distal LED, and there are two diagonals coming out of it. They are very well patent, and we kept it positional, and outcome was quite good. The third case, in a brief, is a non-diabetic normotensive, and presented with unstable angina. LV was 50%, and I'll go quickly through it. And there was a mid-LED lesion which was looking quite borderline, and hardly 70%, but there was an angina elevation, and there was hypokinesia in LED territory. So we went ahead with the IVUS imaging. And in this IVUS imaging, you can clearly make out the very tight lesion in the mid-LED. Here we can see the 270-degree arc of calcium. 270-degree arc of calcium, and lesion was quite tight, the equilucency, but lesion was very short. It was less than 5 millimeter. So lesion is less than 5 millimeter, although it was having a 270-degree arc of calcium. So we planned to go ahead with a cutting balloon rather than rotablation because length was very small, only the discrete lesion. Although it was 270-degree arc, we tried with the cutting balloon as a first strategy for this lesion. This is how you see the 270-degree arc of calcium. And the scoring, or your cutting balloon, 3.5 millimeter, it results in a very good preparation of the bed, and it's very well opened up the lesion. And then we straight away go ahead with the 3.5 28 millimeter stent, and it was optimized with the NC balloon at 16 to 24 atmosphere, and the result was quite good. And on the IVUS imaging also, we are very well deployed stent. And coming to the So the message for this case was, on imaging it was, although it was 270-degree arc, but it was a very short lesion, so it could be easily managed, and the score was less than 2. So without atherectomy, we could manage it. Now these are the final result. Now the last case is a 68 years old male, non-diabetic hypertensive, presented with the ACS inferior wall, EF was 35%, and there are borderline hemodynamics. BP was 85 to 90 millimeters systolic with the EF of 35. So this is a borderline hemodynamics, and this was the angiography picture. Angiography was done outside. So you can clearly see the tight distal left main, and there is a 99% lesion in the circumflex, which was a culprit vessel, and there is also lesion in the LED, which was 80 to 90%. So tight distal left main, circumflex proximal, LED tight lesion in the mid part, proximal to mid part, and there was a right coronary, which was a chronic occlusion. So vessel disease, EF 35%, borderline hemodynamics. So we need we discussed about the surgery versus PCI. Eventually opted for the PCI. So we put an intra-aortic balloon pump as LV support because of financial constraint. Otherwise, we would have gone for the Ampella. And then this is IABP from the right groin, and this 7 French guide from the right radial with the 7 French glide sheath. And then we did imaging first. In this imaging, you can pull back from LED. Let's pull back from LED to left main. You can see there's a calcium which is a 2 to 3 quadrant. There's almost 180-degree arc of calcium in the proximal LED. And this is the distal left main. which also had a calcium, but it was 180 degree, not 270 or more than that. This is the IVUS snapshot. You could see the calcium, which was less than 180 degree, although there was a one calcified nodule. And this is pullback from the circumflex. Here also the calcium was not more than 180. So as the calcium was less than 180, so we planned for the scoring balloon rather than going with the rotablation. This is IVUS snapshot for the circumflex. So this is a 3.5 meter scoring balloon at high pressures, 16 to 20 atmosphere, initially with a culprit lesion that is circumflex. And this is a 3.5 into 28 strand for the circumflex, right from the ostium of circumflex. And then it was crushed with a 3.5 millimeter balloon from left main to LAD. And this is preparation of LAD with a scoring balloon 3.5 millimeter. And then this is a 4 into 48 millimeter stent, left main to LAD. It is crushing the previous circumflex stent, the step crush. And then it was optimized. This is the kissing balloon, 3.4 millimeter balloon in the left main to LAD and 3.5 in the left main to circumflex. And this is a proximal optimization with the 5 millimeter balloon, NC balloon. And now you can see the IVUS pullback. For the time constraint, I will quickly go through it. It was very well deployed stent in the LAD to the left main. You can clearly see some places there is a eccentric expansion. This is the left main. This is the snapshot, very well deployed, good luminal gain. And this is the angiographic image of the left main LAD circumflex bifurcation. And the right coronary was in a stage setting, it was opened up. I will show you the final result with the two overlapping stent. And this is the right coronary artery. So to summarize, the calcified lesions are common finding in routine cath lab practice. Routine diagnostic angio, we commonly found 25 to 30% of cases with the calcified lesions. And angiography usually underestimates the calcium burden. So imaging really helps us in accurate assessment of severity, location, and extent of calcium. We can judge the arc of calcium, we can judge the thickness of calcium, we can judge the length of calcium, and then we can decide the optimal strategy for the bed preparation. And it really helps in managing calcium. If it's superficial, we can use a rota or orbital atherectomy. The deep calcium, we can use the IVL or shock wave. And at times we need a cutting balloon or NC balloon for the bed preparation. And the present day cath lab should be equipped with all the armamentarium necessary for management of calcium. Thank you very much.
Nice presentation, Deep. Yeah. Please, you can. I think very nice presentation, Sanjeev. And I think we'll have a question and answer session later on because of shortage of time.
Yeah, no, my concern is just the battery on my laptop. We'll be all right. Great, thank you very much for the very kind introduction from my dear friend Ravinder. And it's a real privilege to be here back in India, and in particular in Jaipur. I've never been here. I've always read such beautiful things about the landscape and how beautiful a part of the country that it is. I've always wanted to visit. I wish it was a longer visit. This time it's been short. Ravinder and I spent a good deal of time in the cath lab today playing with some complex and calcified lesions. And so it's a real privilege to be able to join you tonight. Over the next couple of minutes, I think we'll talk a little bit about this concept of zero contrast PCI, sort of what goes into planning it, what goes into selecting patients for it, and then what a step-by-step approach is that you can use, even in complex lesions and complex cases, because this in and of itself is not difficult. It's just a set of steps that needs to be followed meticulously to be able to get to a result that you desire. These are my disclosures. So let's start you with a case. This is not a typical case, but this is a regular complex case in our lab. So this is a 71-year-old guy, comes in with a non-STEMI, has the usual cardiac risk factors, only his medical history is complicated. He's a cirrhotic. He has an INR of 2.5. His platelets are 60,000. He has acute on chronic kidney disease as well. His baseline creatinine is 2.7. Now he comes in with a creatinine of 3.3 and in a low flow state with known peripheral arterial disease. He's got the usual dyspnea on exertion that you might expect someone with a heart failure syndrome to come in with now worsening of his chronic syndrome because of his non-ST elevation MI. He comes in and he has an echo, and his echo is an EF of 25%. So starting to get worse in terms of the hemodynamics, starting to get worse in terms of the peri-procedural risk. And then, of course, he's got mild RV dysfunction as well. So we tried to treat this man medically, recognizing that non-STEMIs, there's very clear evidence for revascularization. But it was all about selecting timing. But unfortunately, I remember him getting up telling me that I cannot brush my teeth without chest pain. And he continuously recurred into heart failure, so we were a little bit pushed. So this was his pre-op echo. Okay, not great. Everybody will believe the EF of 20 to 25%. And forgive the stills. These are the diagnostic angiograms that we got from the outside hospital where he was admitted. So this is, obviously a picture of the RCA and a caudal-ish picture of the left coronary system. You can vaguely make out that there's a proximal right coronary lesion and that there's a distal left main lesion. I think maybe a circumflex CTO, maybe some disease here, but we really can't tell. And that's why these pictures are useless for zero contrast PCI. This is when angiography really matters, right? That's as angiographers, as interventionalists, that's our signature. And so if the pictures are not great, they're non-diagnostic. Effectively, we've upfront loaded the risk of these procedures to our patients without giving them any benefit. And that's why the angles and the nature of the pictures have to be so carefully designed to be able to actually bring the benefit that our patients are trusting us with. This, however, was a pretty telling picture. This was useful. So this is Lariche syndrome, right? His ascending aorta just above the renals and below the celiac plexus is occluded, right? So this is now a problem, right? So those of us that are thinking, what are we going to do about mechanical circulatory support in this guy because he's got complex lesions? and he's got an ejection fraction of 25% with kidney disease, right? So in a setting of patients where we know that there may be benefit to offloading some of the LV filling pressures, maximizing renal blood flow, reducing renal venous pressure so that you can increase renal driving pressures and minimize CIN. So why bother with all this, right? This guy's, he's not that young, he's 71 years old. But what is worth telling you is that he's a perfectly viable 71 who is on the list for a liver transplant, right? So this is a guy that we can actually help and get him to a definitive therapy if this is done properly. And what we know about chronic kidney disease in the setting of CKD in the setting of CIN is that outcomes are traditionally very, very poor in those patients who have superimposed CKD and who develop CIN, because this not only is a marker of a high-risk patient subset, but it also may be a marker of poor nephron mass, poor residual nephron mass. You know, we all have those patients with kidneys that have a creatinine of 1.2, 1.3, and some of them will get 150 cc's of contrast and they're fine. And some of them get 30 cc's of contrast and their creatinine goes up, right? So that's a function of residual nephron mass, how much kidney unit you have to actually filter. And what we find is that people with advanced CKD, when they get CIN, they do terribly badly because they have no reserve. And so as their CKD progresses as a result of the hit that we've imparted from contrast, their outcomes dramatically worsen because they end up on dialysis and such. And we know that the outcomes of a 25-year-old on dialysis are about the same as a 70-year-old with normal kidneys, right? And this is probably why renalism, this concept of not offering treatment to patients even though it's indicated because of their chronic kidney dysfunction, exists, right? This is a bunch of non-STMI patients, and you can see that the rate of angiography in patients who have chronic kidney disease versus those who don't is hugely different. And that's because we don't want to hurt patients, right? That makes sense. But as Dr. Rao pointed out a few minutes ago, we're getting into an area where disease is increasingly complex, right? So we are obligated then to provide therapy to patients regardless of what they present at, right? That's our creed. Just because it's harder to do, it doesn't mean the indication to treatment has changed. It means that we need to figure out how to get the job done. So is renalism reasonable? Does it even make sense? Well, interestingly, just as we pointed out, even in modern PCI, so this is data from the ischemia trial, when you look at patients with CKD and CIAKI, they have much, much worse outcomes, even out to 24 months, though those curves separate early. So there's a good reason to discuss how to revascularize patients without injuring their kidneys. We know that contrast-induced kidney injury is largely a dose-dependent phenomenon, though there are some discussions about whether or not there are atherembolic diseases at play as well, and that's something that we can talk about at another time. So what zero contrast PCI is not, it's not a quick fix, right? It's not get in there, bang a stent in, get out. And you have to be aware of that, appreciate that you're not going to be able to do 5 or 10 cases in the same day as you do 3 zero contrast, because they do take time. But these are patients that need you, right? Ultimately, they're perfectly viable individuals, and this is where we are able to really push the envelopes of our practice to be able to get patients the results they need. And the key is, it's not hard. What you see in a lot of these complex PCI procedures are these technical acrobatics, right? Today we had this case where after 5 minutes of rotablation at 200,000 RPMs and 2 burrs, the burr wouldn't cross. So we had to do all kinds of funny stuff to be able to get this vessel open. But zero contrast PCI is different, right? It's all about just seeing differently, just not using the angiogram and using different information instead to achieve just the same result. So general principles, this is not hard, and it's not about working blind. It's about seeing differently. Always start with stability. Never take a patient who has hemodynamic instability to the cath lab in this type of a scenario, because eventually you're going to have to take a picture, right? Whether it's a final picture or if something were to go wrong. And in those patients who are already hemodynamically decompensated, where you have an opportunity to recompensate them, you're making their likelihood of CIN all that much lower. And recognizing that CIAKI is both a dosage and a time function, use staging when necessary. So take diagnostics and stop. Wait 2 days, bring the patient back, and then use the previous pictures to do your zero contrast PCI. This is some data that came out very recently from Ziad and some of his colleagues, where they looked at the severity of chronic kidney disease and LV-EDP. And what you see here is that there's a giant smattering, right? There's no real clear correlation. There's a a very, very gentle curve in the middle. And so what it tells you is that even your most severe chronic kidney disease patients can have a low LVEDP, and even your worst chronic kidney disease patients or your least severe chronic kidney disease patients can have a high LVEDP. And that's why when we look at the data around preparing these patients for PCI, which is largely the Poseidon protocol, right? This is the Poseidon study that documented that peri-procedural hydration is the only real useful form of preventing CIN. This trial used pre-hydration for an hour, right? And then took the patient in and hydrated them during the procedure and for several hours after. But because you don't really know what the LVEDP is going in, your pre-hydration may actually make things worse. As you can see in this group of LVEDP patients, which is a smattering of patients with CKD, some are really not going to benefit from hydration and may be hazardous. Some will benefit, some may or may not, right? And so it's easier than just to get in and get your LVEDP and recognize that based on your LVEDP, you have solid backing to decide how much fluid to give them, right? If your LVEDPs are low, so an LVEDP of less than 13, you're giving them 5 cc's per kilo. If it's between 13 and 18, you're giving them 3 cc's per kilo. And if it's over 18, you're giving them 1 cc per kilo. That's a nicely defined evidence-based metric. So let's go back to our case. Step one, as we said, was planning stability, right? So we checked his hemodynamics. Now this, you wouldn't do a right heart cath on everybody, but this is somebody with an EF of 25%, where the hemodynamics are very germane, and you're not necessarily going to get everything you need from an LVEDP, right? So these were his hemodynamics. Hands up for stable, hands up for unstable. Right, he has a cardiac index of less than 2. His wedge pressure is 28. This is clearly an unstable guy. And in a guy who's got worsening kidney dysfunction, recurrent heart failure, and cold skin with an index of less than 2 on a small dose of an inotrope, he's in shock, right? This is shock. So this is clearly something you've got to treat. And so what we decided to do is go ahead with an MCS device, but we chose an axillary implant. And there's many ways to do this. But this is one picture, so this was 4 cc's of contrast. And this is all that we needed to do this, where we documented the size of his artery, and we selected this nice little window between the thoracoacromial artery and the lung border. It's about a 1 centimeter window. And then using a fluoroscopic marker, so a set of clips, we used an ultrasound to pinpoint precisely where on the artery those clips hit that sweet spot. And then using a 20% angle going through pec minor, we were able to access the axillary artery, place dilators, place 2 per closed sutures like you would do as Dr. Rao does every day in his sleep when he does his structural procedures, and then place a 14 French impella sheath. And through that implant, we placed our impella, right? There's no magic here. So far, we're only at 4 cc's. And that's done very easily through a left radial access, right? 5 French catheter. Another way of doing that is using that same radial access and putting an IVUS in. So what you can do actually is IVUS back, and what you can do is push on the vessel at the point where you fluoroscopically marked your access point, and you will see a depression on the IVUS. Then you assess the vessel at that point to make sure there's no plaque, that you're in a good space, and you can just access there on IVUS. And as a result, you don't really need any contrast at all. You need a very tiny localized injection, if anything at all. If in this case, like this case where you have no disease, you just access. You access just lateral to the lung border, and off you go. So step 2, after we implanted this guy, we sent him back to the CCU. We stabilized him, got his pressures under better control, flogged him with a bit of diuresis, did the best we could, really, but he still wasn't coming off of inotrope. So step 2 was a diagnostic angiogram using a low contrast approach, okay? And this is using the general guide of about 1 cc of contrast per point of GFR, because at that point is where your crude and your risk-adjusted estimates of CIN become relatively similar, and that is exceedingly low, okay? So, and you halve them from when you use a contrast of 2 to a contrast of 1 cc per point of GFR. Your 3 pictures are an LAO cranial for your RCA to splay out the distal vessel, an AP cranial and an AP caudal, both with a little bit of RAO, to show you the LAD and the circumflex left main system, respectively. Now, it's really important to recognize that these pictures have to be done well. So don't do the slow ramp up trickle in. This is one of those pure contrast, marked at 3 cc, so fill up your syringe with no more than 6 cc's, look at it down, and you inject hard and fast. so that you catch everything on cine and then slowly go back and look at your frames to recognize what is where and how to identify your vasculature. Then you can send the patient back upstairs if you have to. In this case, we had an MCS implant, so we didn't need to do that because the patient was getting flow to the kidneys for this period, and 9 cc's for a diagnostic wasn't so bad, right? So this was the ultra-low contrast of the right. You can see the same RCA lesion. And we had a wire down that we put down blindly just to secure the guide, because this is when it counts, right? You can't have the guide blowing back and putting a bunch of contrast into the aorta. And then this is one picture that defines, as you can see here, a very tight osteoramus lesion. You have a circumflex CTO, and you have the distal left main running into the LAD. We have a very capable, very well-trained surgeon in the crowd, and I believe very strongly in consulting on surgical colleagues. We have a very good partnership at my center, and so we all make these decisions together. Is this someone that you would even consider for surgery? With cirrhosis, an INR of 2.5, platelets of 60,000, CIAKI, and peripheral arterial disease with Leriche syndrome, so no aortic flow. Probably not a great surgical candidate, right? Fair? So we're going to push forward to offer this guy the treatment that he needs. This is all the contrast that you get. These were the 3 pictures I chose. I knew what the cranial looked like, and I knew that the distal LAD was okay, which is why I took the LAO call. But that was it. Short, quick injections. The next thing you do is a physiologic assessment of your intermediate lesions, right? So in that ramus that was 90%, obviously I'm not going to put an IFR wire down at the beginning, but I certainly will at the end to make sure that my microvasculature is good and that I've actually reduced and resolved the ischemia due to the lesions, okay? And this works, right? This has been demonstrated in series of zero contrast PCI where what we see pre-FFR has been resolved by post-FFR. So using physiologic guidance in these patients is one way that you're seeing what the physiologic flow is like down the vessels, right? That's really what we care about. But obviously in critical lesions, don't bung up those things. Instead, do what's safe. Get your workhorse wire down, okay? So as I said, we stabilized him on MCS, then we brought him down, we did his pictures. Now comes the intervention, right? How do you engage the guides without taking puffs with contrast? One way to do that is by injecting saline, right? So you do a constant and slow intracoronary saline injection. And what you see are these characteristic T-wave changes. They always go away. But what you're doing is washing out blood and changing the polarization of the myocardium for a very brief period. And that, as a result of the saline, will give you T-wave changes that immediately revert. If you get them, you know you're there. Another alternative is to blindly wire the vessels. But when you've got diagnostics with proximal disease, it's probably better to do this because you know you're not going to hurt the patient. And you have the time to do a controlled wiring to make sure that you are where you think you are. Step 4. So far we've done the hemodynamics and stabilized. We've taken our low contrast diagnostics, and we've now engaged our guide. Step 4 is to create another way to see. That's a wire skeletonization of the vasculature. So pull out 4 wires. Get ready to use them. Use a larger guide if you have to. You don't want to deal with space issues at the last minute. And put wires into every major vessel. So here I put a wire into both branches of the circumflex and the LAD. I left the circ. It was a CTO. I was going to leave it alone because that's not what we're trying to achieve here. We're trying to save this man's life, not relieve symptoms that he may or may not have after he's relieved. And what you'll see is the wire placement's actually important. So do you see the knuckle on the end of this wire? Okay. And do you see no knuckle on the end of this wire? So that's done very intentionally because not only is a knuckle safe, but with that knuckle I can push on the wire. The wire then takes the greater curvature of that blockage. Without the knuckle on the bottom, this wire takes the lesser curvature of that blockage. And so I can be sure then where those 2 wires cross is truly where that bifurcation in the ramus is. Similarly, I pull the LAD wire back from the end. There's no knuckle on that. So that I can keep the LAD wire at the lower curvature of the bifurcation between the ramus and the LAD. That tells me precisely where that bifurcation is. And that kind of positioning is the precision that you need to do this. It's very doable. It's not hard to wire a ramus. You've just got to know what you've got. Okay? The other key is that, remember your diagnostics? You match your pictures precisely, frame by frame, to exactly what you're trying to achieve, right? So make sure that your other fluoroscopic landmarks are lined up perfectly so that you're able to use those pictures as your current diagnostics without the puff, puff, puff. Next, you perform an IVUS assessment of your target lesion. So here you can see there's a bit of calcification. I'm going to speed this up just in the interest of time. And now you've got severe calcification, okay? You pull back, and you start to see the left main, okay? So what you do when you identify these areas is you take a cine at the landing zone that you want. So you identify where your IVUS catheter is set. You then take a cine at your proximal landing zone, right? So in this case, it was the ostium of the ramus because I did not want to turn this into a culotte given the size differential between the LAD and the left main and the ramus that we were going to have to treat as well. So we did IVUS to precisely define our proximal and distal landing zones. And what we did by cineing precisely where the camera was is we knew exactly where to put our stents. Then you balloon up and you do all of the various plaque assessment and treatment that you need. You measure the size of your distal and proximal landing zones, right? So here's your distal, here's your proximal, stenting EEL to EEL, and this landing zone obviously has, distally has plaque in it, so we went a little bit beyond that. And then you take a stent that's ever so slightly longer than you think you need, because the IVUS, if your guide is well engaged, will give you a true length measurement, but because it's outside, can either shorten or lengthen. Generally, actually, it lengthens because the guide goes back and forth as the IVUS is coming back, and that actually artificially elongates the distance of your measurement. Then you prepare the vessel for stenting as required. So we put a cutting balloon in here because it was a very short segment of circumferential calcium that was thin with reverberation artifact behind us. We stented here. We used that slightly longer stent in case our length was off. Then we checked our result using IVUS, and what you'll see is using the landing zones, you can see the stent, you're going to see that there isn't a single strut hang out into there. So there's your termination, right? So this works. You can actually place things precisely, okay? And then, of course, you do the usual stent optimization that you always do, 90% your distal MLA. Recheck your post-PCI physiology. That's really important to make sure you get the result that you're going for. So then in this case, we did the other part. This was the easier part. This was just a straight stent from the left main into the LAD, optimized. And now this is your PCI coming back from the LAD. Okay, this is your stent coming back into the LAD. You'll see the ramus stent come up. Okay. So once again, you're getting a reasonable result there, right? And this was then 3 cc's, and this was the other 3 cc injection. You're done. That's it, right? So your actual procedure took 4 cc's for your MCS implant, 3 cc's for your final picture, and you just did a left main trifurcation. Oh, and by the way, we fixed the right too, right? That was another 2 cc's, and this was easy. There was no brains to this, right? It's just cross balloon, crack it open, and stent it. So that's it. That's the whole trifurcation in this guy. And then pulling out the impella was easy because, contrary to popular belief, the axillary is a compressible vessel. We already had percloses in. We put a balloon up across so that we could tamp the percloses down onto the balloon. That allows you to do a dry closure. Okay, you can see that little balloon where you're tamping down the percloses using a dry closure technique. And your procedure is done. Now, sometimes you do have to take a picture. It's safety first. So when do you take a picture? Unremittent chest pain, EKG changes in a major territory that persist. Sometimes when you atherectomize, this happens, but it goes away shortly thereafter. A new effusion, so remember, peri-procedural echo is absolutely critical. A CFR, your coronary flow reserve, of less than 1.8, which suggests microvascular dysfunction, particularly in the setting of atherectomy. And then an ischemic FFR post-PCI, because it means you probably missed an edge dissection or a distal lesion. And this is what I was going to talk about with access. I realize a 7 French guide sometimes is hard to get up the arm of an Indian female. And so you can use balloon track and these kinds of things to facilitate that. But this is why. Because your descending aorta looks like this. And your ascending aorta looks like this. And that's probably why there's evidence to show that with radial access and smaller guides to do your diagnostics, you actually get less CIN. So imaging and physiology guided PCI, the so-called zero or ultra-low contrast PCI, isn't hard. It's a very doable type of procedure. I don't recommend you start with a left main trifurcation on an impella via an axillary. Start with a simple LAD. And when you do that, you're likely to get the result that you want using best practices and using just these simple principles. Thanks very much for your time and attention. Ravinder, I'm going to have to charge my laptop, so maybe I'll hand it to our next speaker. Is that okay? Okay. Because I think it's about to die. And if anybody... it before I can do any other talk.
So either question answer session or we can later on. We have to interactive. Yeah, yeah.
Yeah.
No contrast, ultra low contrast. And second thing, is there any alternative of this zero contrast, ultra low contrast to CO2 angiography?
Excellent question. So, in respect of the definitions around zero and ultra low, the other ones are just euphemisms. Zero is zero. That's easy. Ultra low is defined colloquially as less than 1 cc of contrast per point of GFR. But there is no formal definition in the literature of that. We're sort of working on it now, actually, where we're collecting ultra low using a 1-to-1 ratio versus true zero and comparing the outcomes. Because I think that there is a lot of resistance and discomfort leaving a procedure without taking any pictures at all, even a final picture, right? And I can understand that. I think that makes sense, though when you've got the IVUS, you've looked everywhere, right? You've got the physiology, you've proven everything is fine. So, I mean, I've done left mains with true zero, with nailing the ostium using IVUS. These are all very safe procedures. There are no issues there, you just have to be careful to follow the rules, right? The post-procedure echo is critical, making sure you make sure the physiology is normalized is critical, making sure your IVUS result is perfect, these things. I suspect that ultra low is going to be clinically just as good. And ultra low to the average individual makes them comfortable, right? And is safe. And I think most importantly is going to help adoption of the therapy because there are so many kidney disease patients out there. And they do, contrary to popular belief, contrary to the early results of ischemia CKD, benefit from revascularization. The challenge of a lot of these patients when you do ischemic testing is we don't know whether or not they're actually ischemic because a lot of the calcium that kidney disease patients get is in the media, and media does not respond to vasodilators, right? Calcium doesn't respond to vasodilators. So, you know, we may not have selected the right patient group in that particular trial, right? We know that when you go out to 4 years, you get a benefit from a spontaneous MI perspective, even in ischemia. So I think these patients do need treatment, and I think using a potentially ultra low contrast approach may get you the same outcome. We just have to prove it. And then your second question was?
CO2 angiography.
Right. So the problem with CO2 angiography is it's the heart, right? And when you've got CO2 going into the heart, it won't clear as easily through the microvasculature, which is why CO2 angiography has never been done in the heart. Certainly it works very, very well in the legs. We do it in the legs. And that's because the number of outflows that the legs have is huge. And when you look at those, does anybody do peripheral arterial interventions in here? Yeah? If you've ever seen geniculate collaterals, or even collaterals, our surgeons here, so this is a classical exam question, right? Collaterals from the lima supplying the distal leg, right? The classical surgical exam question is you take the lima, and then the patient leaves the OR, and the leg is blue and cold, and that's because you didn't check, right? Those collaterals are huge. They're very, very big. And as a result, there's lots of capacity in them to carry and clear the CO2 that's used in the angiogram. The heart doesn't have the same benefit.
Second thing, when we were learning the radial at ICPS, the classical teaching was like that when there is a CKD or a CI, you have to skip the radials because patients will need.
Yeah. So this is a great question. The question was the classical teaching in chronic kidney disease patients is don't use the radials because they may need a fistula for dialysis. And often, if you're going to take them to surgery, surgeons don't like using the radial that's been used. This is a fair point, right? This is the interventional cardiologist talking, not the nephrologist talking. And so we always have to balance these risks. If I submit to you that if you have someone who's CKD late stage 4 and is probably going to be on dialysis sometime soon, you probably shouldn't go radial. You should probably go femoral, but still use the zero contrast or low contrast approach because residual renal function is the most important marker of their outcome, right? And so you fight to preserve that residual renal function. And the beauty is intravascular imaging is a very easy technology to use. Intercoronary physiology is a very easy technology to use. And so we can get away from the idea that we don't see, even when accessing the femoral, and just say that we are seeing differently, which is from the inside instead of the out.
Yeah.
Yes, Professor.
I just wanted to ask you, like, whenever you're planning a case, you plan to be doing it zero contrast and land up doing, say, low contrast or ultra low contrast. So are there any preemptive measures you would like to take because you may have planned it to be a zero contrast procedure, but ultimately you'll end up into, say, maybe low contrast or ultra low contrast. So
Right.
does that change your strategy? You keep that in mind before you start the procedure, or
Yeah.
it's absolutely clear in your mind that, okay, I'll go for low contrast or I'll go for zero contrast, and that's it?
So this is a good question as well, which is what's your philosophy on contrast use in general, right? I mean, we're in a worldwide contrast order, so this is kind of timely. But I think thank you very much. I think whenever you use contrast, you have to continuously tell yourself that you're poisoning the patient just a little bit, right? It's of no biologic benefit and only biologic harm. So every case I do, I go in with the approach of I'm not going to take extra pictures if I don't have to, because all I'm doing is hurting the patient. There's just no good reason to do it. But does that mean that I image about 90% of my cases, but does that mean that I follow this relatively detailed multi-step protocol? No. My headspace on those patients is when you're starting to hit, your GFRs of your CKD stage 3s, your GFRs of 30, those are patients that are really at risk. 40s, those are patients that are at risk. GFRs of 50, I think if I go in with an upfront one-to-one, contrast volume to GFR approach, I'll be fine. But what I don't do is recognize that any patient with CIN is not at risk. Any patient with CKD is not at risk. So if you have a GFR drop, if you have a creatinine elevation, if your kidneys are bad, you get an ultra-low contrast approach or an intended ultra-low contrast approach. Safety always comes first, right? Sometimes you have to take a picture. But the idea, if you've got any chronic kidney disease, is always to approach it with low contrast. The other planning things that are important, and these actually can't be emphasized enough, is never take a patient that is unstable for an intervention that can be done when they're stable. It doesn't make sense. So the typical one with patients who come in chronic kidney disease and heart failure is you treat their heart failure. You dry them out. You make sure their hemodynamics are optimum. That was step one, right? But that's just good medicine. There is some evidence to show that statins, pre-procedurally, will reduce the risk of CIN. The only therapy intra-procedurally that's been shown to reduce CIN is hydration. But as I mentioned, it's not pre-procedural, it's peri-procedural, so during and then afterwards as LVEDP guided. And then, of course, the other major therapeutic advance is contrast nihilism, right? It's a reduction in the amount of contrast that's used. So all of those things I think are important. Staging the right vessels are important. So generally speaking, when you're doing a low contrast study or PCI, what you want is the largest bang for your buck at the lowest risk. So if someone has like that RCA that you saw, my intention there was we were on an MCS, we were going for gold and getting everything. But if you don't have that, and you have that RCA that we saw with a tight 90% lesion proximally, that's a great vessel to pop open and do and stop. And then bring them back 2 days later and do the other stuff. Because you don't have to stack things. Every time you do any intervention, because contrast doesn't contain hemoglobin, right? And we have to put balloons up to occlude blood flow when we put our stents in, you are by definition making the myocardium ischemic. You're making it stiffer, its lusitropia is getting worse, its LVEDP is going up, and your renal driving pressure is going down, so your risk of CIN goes higher. So as you stage, you reduce that because it gives you the opportunity to optimize again and again and again. The other piece, now there's one piece of data that looks at staging. It's a paper by Janani Rangaswamy, who's a good friend and the first author of the cardiorenal guidelines at AHA. That actually shows more contrast use, but no difference in the rates of CIN. Of course there's more contrast use. You staged procedures. But using an ultra-low contrast approach, you often don't have to do that. You take your 9cc pre-PCI contrast, angiogram, and then you're done. And you can, with modern fluoroscopic technologies, put your previous films right up on the screen and follow those as your reference, and then do your case, right? So I think that's the sort of sum up. But probably the most important one of all of those is be sensible, right? Don't take a patient for a procedure when they're unstable, when you can stabilize them. If your hand is forced, then just be careful.
Questions from audience? So I think that was a great talk, Sanjog. Just few things which I want to ask you, or maybe I want to comment. One of the reasons, one of the device for kidney protection is actually mechanical circulatory support.
Yeah.
So one of the indications for Impella is if you're doing a high-risk PCI and your creatinine is borderline. And second is IABP. My one direct question to you, which we face very commonly in our clinical practice and everybody faces, is patient 65-year-old, triple vessel disease, diabetic, GFR of 30 to 50,
and creatinine of around 2.5. Is
Yes.
cabbage better for his kidneys or is PCI better for his
Yeah,
kidneys?
so this is coming back after sort of your recent revasc guidelines in stable ischemic heart disease, but also the question of what surgeon you're working with, right? So if you're going to get this guy an off-pump cabbage with total arterial revasc, if you can, and a very competent anesthesiologist, I'd send that guy to cabbage every time. If not, then it isn't just us or them, right? It's about finding the right therapy for the patient. And so, Dr. Chakraborty and I had a nice discussion earlier today where this might be where hybrid revascularization lives, right? Where I don't think that even with imaging guidance, we can beat a Lima graft today. Maybe one day, but not today, because there's all of the antioxidants and all of the EDRF and nitric oxide, these kinds of things that get generated in the Lima that are constantly perfusing the myocardium, that I think is a benefit to these patients with diabetes, because contrary to popular belief, they don't have small vessels, they have diffusely diseased vessels. And so they need all of the microvascular vasodilation they can get, right? But putting a Lima onto an LED and then bringing the patient back 2 days later for staged PCI to the CERT to avoid having to open the chest, avoid having to deepen their anesthetics, even potentially doing them under a local so that their pressure remains stable, that might be the best approach for the kidneys.
So one more question which we can ask all our audience and our expert panels. How many of us do LV-EDP measurement before we start IV hydration or before we start a complex PCI? So maybe today we have learned from your talk, we're going to put a JR catheter, measure an LV-EDP and start hydrating. The other thing which we practice is, suppose we have a high-risk patient, we want to hydrate. Instead of doing an LV-EDP, you can do an E upon E prime. And you can get an idea of LV pressures and LA pressures, which can also help us to hydrate these patients in the ICU settings.
Absolutely. The worthwhile note, I mean, in this patient, as you probably noticed, there was a right heart cath up, because there's no such thing as a high-risk PCI that gets done without a right heart cath. If it gets done without a right heart cath, this is provocative. If it gets done without a right heart cath, it's malpractice.
One more thing which Sanjog, I mean, you pointed out cardiac output, cardiac index. Sometimes our hands are limited because we don't have thermodilution catheters. But
No, that's okay. Fair.
What we can do is the mixed venous saturation.
Yeah.
So the simple measurement, the mixed venous saturation was 50%, which clearly tells us that patient is a low cardiac output. That's what we do sometimes. Just put a catheter in the pulmonary artery and you can continue drawing the mixed venous saturation, which can be
That's an important comment. I think there's a couple of little caveats to FIC, right? You need to make sure that the hemoglobin is within a given range, right? And then the PA saturation in the absence of a hemoglobin is good as a trend. It's not good as an absolute value because you need to actually put it into the FIC equation. And we recognize that there's about a 30% error in indirect FIC, which is what that is. But it's a good guide, right? It's a very reasonable guide. You don't have to do thermals on everybody. And the important piece is that you can actually monitor the pulmonary pressures as you go. Your earliest signs of ischemia in these types of patients, your earliest sign that something bad is happening is your PA pressures go up. And so because you have a right heart cath in, you can take 300 of nitroglycerin, put it right into the right heart cath, right into the pulmonary artery. That will increase the pulmonary venous capacitance very quickly. You'll drop your left atrial pressures very quickly, and your patient doesn't end up getting intubated on the table, right? That's the key, right? Because the moment that happens, they peripherally vasoconstrict, they live on sympathetic drive, you sedate them, they crash, right? That's just a mess, all with wires and these kinds of things in the arteries already. So instead, you follow the right heart, you see trouble coming, and then you can nitro and you can Lasix and these kinds of things right into the pulmonary artery so that they circulate quickly and you affect the local vasculature and keep the patients from even getting short of breath.
Ravinder, apart from adequate hydration, I think we must use the isoosmolar contrast.
So again, we can ask him, difference between isoosmolar and non-ionic.
So the isoosmolar contrast is the one with the most data on it. I think we're pretty clear that moderate osmolality and high osmolality contrast is a clear no-no because the rates of CIN and rates of injury are significantly higher. The isoosmolar contrast versus non-ionated contrast mediums, I don't think they've ever actually been compared head-to-head. But the rates of CIN when we compare these various studies are all using the same isoosmolar contrast, right? So the idea is not that it's iodinated versus non-iodinated, right? The issue is its volume, right? And keep in mind the ionodated contrasts, those tend to be higher osmolality, right? So if you're using isoosmolar, you've still got to keep the doses down. That's really the bottom line.
Great.
Any rule of NSL sustain or Sodabeka?
So not a ton in the literature, right? There's like one small study that showed maybe some benefit, but the question was, it was just the hydration that they gave next to the NSCL system, right? There's this discussion right now around mechanical circulatory support and chronic kidney disease. That comes from a single paper by Flaherty. It was retrospective data, okay? It was subject to a gazillion confounders, and so it needs to be studied systematically before we start to recommend it in guidelines. But for what it's worth, the number one reason for type 2 cardiorenal syndromes, right, the ones that we encounter as cardiologists, are issues of renal driving pressures. The heart is stiff, right? It's relatively small cavity. These patients all have LVH, right? Even when they're remodeled, they're not remodeled that well. And most importantly, their CVPs are high. So if the pressure in the afferent arteriole is not that much higher than the pressure in the venous system of the kidney, right? So the amount of venous congestion you have is a reflection of the pressure in the venous system. Then your GFR, which depends on the gradient between the arterial pressure and the venous pressure, is going to be low, right? It'll be at your lowest point, which is why it's so important to hemodynamically optimize these people. The number one predictor of bad outcome in shock is a high CVP, right? The shock trial looked at all these, cardiac output, cardiac index, cardiac power output things. But when you look at real world shock data, right, the cardiogenic shock working group, and you take 1,000 patients from high volume shock centers, and you analyze all of their hemodynamics, the one that comes out on top as the worst predictor of outcome is a high CVP, because it bungs up everything, right? You reduce driving flow across all of your arterial beds. And so in those types of situations, the key with mechanical circulatory support probably isn't that we're flushing the kidneys with arterial blood. It's probably that we're allowing the kidneys to see a higher perfusion pressure relative to the renal venous pressure. And it may be allowing us to diurese them such that the renal venous pressure drops, and we are allowed to then create that renal driving pressure we need to create a better GFR. That's likely what's going on, and you're going to see the results out of PROTECT 4, which has a renal sub-study embedded within it. Those results are several years off, but that's really the definitive trial.
Irrespective of renal function, we should try and minimize the use of contrast, even for the patient with normal renal functions.
Absolutely.
Same as the radiation, we should try and use bare minimum contrast in our routine practice also for them.
Absolutely. Contrast is poison. There's no biologic benefit, right? If you want to talk about saline in someone who's dry, right? Sure, it's only a third of it is going to stay intravascular, but what you're doing is giving them plasma, right? You're giving them a blood pressure. You're giving them renal flow. You're allowing the organs to get perfused while you get everything sorted. Contrast is providing them no biologic benefit, zero. Therefore, it doesn't need to be there, right? The difference between a drug and a poison, this is Paracelsus, right? This is the father of toxicology. The difference between a drug and a poison is the dose, right? So in this case, remember, right, that this drug that we used to be able to see becomes a poison very quickly.
Right, Sanjog. Thank you. Thank you very much, Sanjog. We had a beautiful discussion. And
thank you.
After having the discussion, let's have a case presentation. The first case presentation is by Dr. Deepesh Agrawal. He is a professor in the Mahatma Medical College. So, Dr. Deepesh, can we have?
So we are using so much of dye to our patient, in fact, in renal patient and all the patients. So definitely we should try to use less dye and if possible no dye like things. So here I'm asked to present one case, calcified coronaries, that is simple case, not a very complicated. So this was a 63-year female admitted with complaints of chest pain of 2 days duration with breathlessness on exertion. And she was known diabetic, hypertensive and hypothyroid. begin with, vitals were stable and ECG showed STT changes in inferior leads, that is inferior wall ischemia. And echo showed RWMA in inferior wall lesion with ejection fraction of 45% with trivial MR, and otherwise that was normal. So the diagnosis was CAD, ACS, unstable angina, diabetes, type 2, hypertension, and hypothyroidism. Cardiac marker was not great so much. Angiography showed in LAD there was a proximal to mid tight lesion, and that was calcified. Otherwise, in proximal circumflex there was a plaque, and RHL showed 99% thrombotic lesion in proximal to mid part. So, in view of inferior wall ischemia, I tried RCA first with the radial approach, 6F JR catheter. And initially, I usually in acute coronary setting, I usually do thrombosuction to take out the clot burden. So this was thrombosuction and pre-dilated with 2.5 into 18 for 12 atmospheric pressure, and it was implanted with the stent 3.5 into 44 at 12. So RCA was fixed. Then comes LAD. So after wiring this LAD through the radial approach, I was unable to cross any device, any balloon from this proximal part. So the next was, should I go for rotablator in this case, or should any other method we should try? So I tried with a 2 wire and 1 into 10 balloon, 1.2 into 10 balloon, but I was not able to cross anything. So I exchanged this wire with the rotablator wire, and then I decided to go for rotablation. So this was rota. This was 1.5 millimeter bar in the proximal part, and it was after rotablator did the IVAS, and that showed a significant calcification in the proximal to mid part. You can see this was fibrotic, and then calcified lesion starting at 6 o'clock to 9 o'clock, and then almost 360-degree calcium in the mid part. And the calcium is involving deep into the up to the adventitia, also in the 3 to 6 o'clock position. So with this, this was the rota images in the mid LAD, which showed the MLA of 2.7 millimeter square with a good amount of calcium in between. So then I decided to go for IVL to break the calcium if possible. Then IVL was failed to negotiate in this lesion. Then I did the pre-dilatation with NC balloon of 2.518 and 2.75 into 15 for 12 atmospheric pressure. And then I could negotiate IVL with 3 into 12 for 6 cycles. Now during IVL, the patient developed sudden hypotension, and there was a very sluggish flow in LAD. And I could do only 6 cycles, not 10 at that point of time, and I had to stop the procedure in between. For around 5 minutes I had to stop, and then flow started, and then I did the further procedure. This was the post IVL IVAS. Which showed breakage of calcium in 6 o'clock as well as in 8 o'clock position after IVL therapy. There was multiple fracture segment was visible at that time. And then post dilatation, the MLA I could achieve was 6.4, and then I implanted 3 into 33 at 12 atmospheric pressure from ostium of LAD to mid LAD. And then serial post dilatation was done from proximal to mid LAD, which was 3 into 18 and 3.25 into 15, 18 atmospheric pressure balloon. And this was the final post PCI IVAS imaging. We showed good apposition and proper expansion of the stent from the mid to proximal LAD part without any distal dissection or good coverage of LAD ostium in the last. So LAD ostium was well covered with stent struts. So this was the final result of that. Thank you very much.
Wonderful So any question from the audience?
My question to you is, once you finish with the bar, right, 1.5 bar, and then you did the IVUS, the calcium arc I saw didn't look like 360 or 270, and then the IVL was done. My question is, if instead of IVL, we would have taken a balloon, compliant balloon, 1:1 artery ratio, and just tried it out as a test that if it expanded 3 to 3 or 2.75 to 2.75, do you visualize that as an alternative, that if the balloon would have expanded and then go after the stent without doing the IVL, since you already did the birth? And second, I couldn't understand what was, or what did you thought of that right after the IVL, the flow was reduced, or what exactly happened?
So actually, it was not planned to go for IVL at that point of time. After doing rota ablation, I was not able to negotiate balloon in that artery again. And that basically, in that part of time, I tried 3 balloons, New York balloons. And again, I was not able to negotiate properly in that point of time. So then 2.5 balloon probably that negotiated at that point, I dilated that. And then I decided to go for IVL to break the calcium. Otherwise, definitely after rota ablation, simple ballooning is sufficient. Or many a times I used to do cutting balloon if it is not possible to negotiate in that lesion. So that was the reason.
Actually, a few days ago, we were also stuck up like this. We did the burr, 1.5, and nothing would go even after doing the burr. So much so, it's so calcified that the burr, just jumped off. It came out. So anyway, after doing that, we are stuck up and we didn't know how to proceed from there. What we did was, using those guideliners or telescope, they might help in such a situation. So much so in this case, even after we had dilated, the stent would not go. And again, the telescope came to our rescue. So maybe that's one thing. And yeah, that's important.
So similar, actually, day before this case, I stuck up with a severely calcified lesion, and that lesion, my stent was dislodged. And that was dislodged in the left main just because of calcification. I was not able to negotiate that stent at that point of time. So I had to withdraw and I had to retrieve from the other side. And then after that, I used cutting balloon and I took guideliner, and with the help of guideliner, I could negotiate that stent. So I was a bit afraid of all those episodes because it had happened one day before. So I straight away took IVL in that.
I guess you had some no reflow with IVL. How often do you see that? Why do you suppose you saw it here?
So actually, we are not doing regular cases like this with rota or IVL. But yes, in calcified lesion, if you go for rota ablation and the cutting balloons like this, so they are definitely have no flow and slow flow situation. So in these cases, we usually go with the good amount of nitroglycerin as well as deltiazem in that point of time, or sometimes tadalafil.
Ravinder, you have a lot of experience with IVL. How many times have you seen?
So I think, first of all, congratulations for the great
Excellent case, great result. By the way.
Yeah, and that was like a state-of-art angioplasty, because that's what is published in Eurointervention. You need to have an imaging, all atherectomy tool, and then only you can beat the data of Syntex Ven trial. So answering your questions, I'm going to present that, how to avoid slow flow and all those things in rotablators. But one important thing is, if you continue giving IVL pulses without letting the artery breathe, you're going to have a slow flow, no flow, because the microvasculature is becoming hypoxic. So you inflate, then you deflate, and let the blood pressure come up, let the ECG changes settle down. And then you inflate again. So between 2 cycles, the ECG changes have to come back to normal. If there's a low blood pressure, the blood pressure has to come back to normal. So you allow the microvasculature to breathe. Number 2 is, we sometimes don't do this in a thrombotic lesion. So this is what I practice, and up till now, I haven't had any no flow. But if you continue inflating it, you will have a no flow.
Congratulations, Dr. Deepesh, for your nice rotatripsy case. I just want to ask Dr. Kalra, in this patient, this is acute coronary syndrome, he did the thrombosuction in right coronary artery. What is your experience to perform the rotatripsy in the lab system?
In the setting of an acute coronary syndrome?
This patient was having the acute coronary
Sure.
syndrome. He did the thrombosuction.
Yeah,
And
yeah.
secondly, he did the rotatripsy in the lab system.
Yeah. So I have no issues during your rotatripsy in the setting of an ACS.
When
Done
we are
that many
discussing
times.
about the no flow, slow flow,
But But yeah, so the issue is, what was the mechanism of the no flow, slow flow? Because that's where I was sort of going with this, right? So it's not thrombus, right? That's the point I'm making, is you've demonstrated very capably that the problem here was not thrombus. And rhoda, sometimes you have to do. Frankly speaking, I think if you're having trouble delivering a stent nowadays, it's because you've underprepared the vessel, right? You know, stents are very deliverable, right? The guideliners, these kinds of things. If you can't get your thing to the site of where you need to go, you probably have to do some more work on the vessel. The mechanism behind slow flow in IVL is not very well understood, but it is actually a described issue with IVL. We think it's probably because as you create shards, you may create some thrombotic debris near the balloon that embolizes. There may be a component of lipidic plaque that underlies the calcium that is liberated that then embolizes. Maybe something else, right? It's not totally clearly understood, but there is a group of patients who do end up getting slow flow. I don't think it's predictable though, right? I don't think it was the thrombus in this situation because you really capably dealt with that. And I don't think that if you had waited a day or 2 days, you would have been any less likely to get slow flow. The problem was the use of the IVL and what it did, right? Nobody's saying you didn't, like, I don't know if you could have gotten away without it. I mean, the other talk that I have is when to use what balloon, right? So we can talk a little bit about how to refine the selection. But yeah, I don't think it was the wrong thing to do. I think this is a described complication that we underreport with IVL, and we're going to learn a lot more about it as more and more data come out.
So that means in these kind of situation, apart from vasodilator, a good amount of GP2B3 inhibitors or heparin may work.
Yeah. So with rotablation, the 5 risk factors for slow flow, no reflow are a burst speed over 150,000, a burst size over 1.5, a lesion length over, I think it's 25 millimeters, the lack of pretreatment with some sort of antiplatelet agent, and long runs, right? So minimize those things. As far as IVL goes, again, I don't think we have enough experience with it to be able to really characterize why it happens, but it does happen. And that's why I asked the question, because Dr. Rao is a high volume operator.
So to answer that question, so instead of using a lot of 2B3A, I think the risk of bleeding increases in the presence of newer generation antiplatelets. So what we are using is we are using a lot of intracoronary verapamil and adenosine. These are the only 2 medicines which are class 1 indication. Third one is SNP. What we use intracoronary, you can use intracoronary integralin, which could be 10 milligram followed by 10 milligram, total of 20 milligram boluses. But I think the practice can vary.
So the only caveat that I would, and I mean, Ravindra and I will go back and forth about this. I love the adenosine. I love the sodium nitroprusside. But in patients who have slow flow, who have developed LV dysfunction, I don't like verapamil, right? I realize that it's a very good vasodilator, but if you've got someone with an EF of 25% and you give them a bunch of intracoronary verapamil, or worse, you give them multiple aliquots, that may not be the right choice in that situation, though I'm sure with Dr. Rao's patients, you know, not only does this not happen that commonly, but he'll use the other drugs in those types of patients. The last thing you can give is intracoronary epinephrine, right? So a 1 in 10,000 dilution, where you take an ampule, which is usually given to you as 0.1 milligrams per mil, so 100 micrograms per mil, dilute that into 20 cc's so that you have 50 mics per mil, and give 2 cc's. So you've given them 100. Be ready. They're going to get tachycardic. They're going to have some discomfort, but you will open up the microvasculature a lot of the time.
I've done once only.
Yeah, it works. It works. It sucks, but it works.
No, absolutely, you're right. Basically, we have done 70 cases of IVL, and we have got two events in which we had slow flow or no flow. Basically, since then we are using 2 things. First thing, always give some time to the artery to breathe. Between 2 cycles, please give them at least 5 to 10 seconds. And second, in almost all cases of IVL and almost all cases of rota, we are giving epiphyotide.
Yeah.
So basically, there was a concept of ghost platelet. Basically, during the rota or during the IVL, you are damaging the platelets, and they release some factors that causes the slow flow and no reflow.
Certainly, yeah. There's a lot of platelet.
Questions from the audience? Yes.
I want to ask Dr. Kalra. You said a burr size of 1.5 in the risk factor of causing slow flow.
Bigger
But-
than 1.5.
Burr size of 1.5.
Bigger than 1.5.
Bigger than 1.5. So it's okay then. Actually, I heard what we are using, most of us are using 1.5 as our starting
75% of root ablation is
Yeah,
1.5.
that
Actually,
is what I
75.
heard.
Any more questions? Sorry, can we move to the next case
Yeah, I think
presentation?
Move the queue. Thank you very much. Yeah, we are going to have a second presentation by Dr. Anshul Kumar Gupta. Anshul, he is a cardiologist at Manipal Hospital. He is a great guy. He was with me since last 6-7 years.
Thank you, sir. Thank you for the introduction and a warm, very good evening to everybody. With the wonderful presentation by Dr. Dipesh, I also have a very simple case. I mean, it was actually a high-risk patient with a triple vessel disease. So this happens to be a 77 years old lady, known case of type 2 diabetes, then hypertension, hypothyroidism, and she had rheumatoid arthritis. So a lot of comorbidities were there. And she came to us with history of heart failure. That is, all the symptoms were there: dyspnea on exertion, swelling of feet, abdominal discomfort, distension for last 10 days. And she had history of such recurrent hospitalizations in peripheral hospitals over several times in last 6 months. On examination, she had pallor, bilateral pitting pedal edema, then raised JVP. There was tachycardia and a stable blood pressure of 130 over 80 millimeters of mercury. ECG showed Q waves in the inferior leads, and an echo showed an inferior and inferolateral wall severe hypokinesia with an ejection fraction of 30%. Her biochemistry revealed severe anemia with a hemoglobin of 8 gram per deciliter, creatinine level borderline with 1.7 milligram per deciliter. The rest, all other investigations were more or less within normal limits. Now, she was stabilized for almost 36 to 48 hours with medical therapy, including 1 unit packed cell transfusion, and then she was taken up for a coronary angiogram. Here we can see in her coronary angiogram, the left system is moderate to severely calcified. The left main, LCX, LAD, all have a lot of calcium present. The LCX is dominant and severely diseased. As we can see here, mid LCX is almost subtotal to total occlusion. The major obtuse marginal is again diseased. In the right coronary artery was non-dominant and diffusely diseased. Coming to LAD, here we can see a large type 3 LAD with a tight lesion in the proximal part, which is moderate to heavily calcified. And as we can see here that the RCA is almost non-existent. It is a non-dominant artery. LCX was severely diseased, and on echocardiogram almost it was thin and akinetic territory. So what we have here is only LAD, which is the surviving territory here, which is supplying a large size territory. So the options of revascularization in this lady, considering so many of comorbidities, bypass was discussed with the patient attendants, but obviously it was a very high risk bypass. So we decided to go ahead with an angioplasty of LAD. So a 7 French right femoral access was taken with a 7 French EBU guide catheter, and a TPI backup was taken. This lesion was crossed with a Workhorse BMW wire, and a pre-procedure intravascular ultrasound was done. What we see here on IVUS pre-analysis is that we have a lot of calcium throughout the proximal to mid LAD segment.
There is a 360-degree arc of calcium in the distal LAD with a very low minimal MLA. There are calcium nodules in the mid part of LAD. When we looked into the ostial LAD, the MLA was around 7.96 with a 52% plaque burden. So though there was a lot of calcium nodule present here, but the MLA was okay at 7.9 millimeter square. Then the BMW guide wire was exchanged over a microcatheter with the help of a microcatheter to a floppy rota wire, and multiple runs of rota ablation were done with a 1.75 millimeter burr to rota ablate the proximal to mid LAD calcium. This is the check angiogram. After the rota ablation, we can see there are fine dissections in the calcified area, and there is a good distal flow. So we decided to stent the vessel now. Then pre-dilatations were done with 2 into 12 millimeters of non-compliant balloon and 3 into 10 millimeters OPN-NC balloon at a high pressure of around 45 atmospheres. So next, this is the check angiogram after the bed preparation part. We can see that the proximal LAD has opened up and there is a good flow now. So the proximal to mid LAD was stented with a 3.5 into 38 millimeters stent from proximal to the mid part. Since the ostial LAD had only calcium and there was not much of the plaque burden, the ostium LAD was not stented. Landing zone in the proximal part was in the proximal LAD, and it covered in the distal part, it covered up to the mid LAD. Then serial post dilatations were done with a 3.5 into 12 millimeter non-compliant balloon, followed by a 4 into 10 millimeter non-compliant balloon in the proximal LAD part. Post-procedure IVUS was done. Now we see here that we have achieved good MSA here. The vessel had opened up well. There is good in the longitudinal section as well as the cross sections here. We can see there is well expanded and well opposed stents with no major dissection in the distal part or the proximal part. The MSA that has been achieved in the distal LAD is 8.9, then in the mid part again 8.95. Proximal LAD showed an MSA of 9.49 millimeters square without any major dissection in the proximal or the distal part. The final check shoots showed very good result, TIMI-3 flow in the artery, and so this lady was discharged after 2 days, and she has been in regular follow-up for the last 1.5 years, and she's doing well on her medical therapy now. We decided to assess the LCX with a PET scan later, but due to financial constraint and the family reasons, she did not go for that, and she was doing well only with the medical therapy. Now she has almost NYHA class 1 to 2 symptoms only, with an ejection fraction of 35 to 40%. She also did not have any recurrent hospitalization after this procedure.
Nice presentation. Any question from the audience?
I'm Dr. Ashish Gupta. I'm working as a consultant cardiologist in Krishna Heart and General Hospital. Sir, excellent effort, but my just one comment was our conventional teaching was with rota. It is generally class 3 in a single surviving artery. If anybody agrees with me.
Nice case, Anshul, but my comment is that in a single surviving vessel or with poor ELV, without putting any mechanical support system, in this case, taking such a case for rota, is it recommendable, or we should try this thing in our cath labs, or should avoid without any mechanical support if we are taking such a case?
Hello. Yeah, very relevant question, I'll say. We were ready with an IABP. We had an extra left femoral approach sheet present also, but didn't put it at the outset because the patient was tolerating the procedure well. We do have IABP and ECMO support with us. We were ready with an IABP, but didn't put it at the outset in the beginning itself.
I think usually the classical teaching, last remaining artery, rota should not be done. But I must congratulate Dr. Anshul. He did very nicely, and he kept IBP and ECMO standby. So I think he came out, but classical teaching is like that. In dominant circumflex and 100% RCA, it should be done cautiously.
Just because our session is only on calcification and rotablators, we will not discuss the circumflex part. But just one comment on anybody. How would you like to do a complete revascularization on follow-up for this patient? Because this patient has low EF. So at least maybe it should be attempted, a complete revascularization. But great case, congratulations. Maybe we have learned from Sanjog's talk that we should do an EDP from now onwards if we are attempting this case. And if EDP is high, IABP at least is better than nothing. And the shock trial showed us that if you put an IABP when the patient is crashing, it is of no use. Great case, great presentation. Thank you very much.
Thank you, Anshul. Now I invite Ravinder for the next case presentation.
I have a talk. The talk is rotablation in complex lesions and unconventional situation, planning and execution. So all of us who are gathered here and along my respected teachers and all seniors and colleagues also, we all are experts in rotablations, and we are doing it just we have to choose our patients wisely and we have to prepare the patient correctly. So I'm just going to discuss a few headings, which is CTO balloon and fine cross not crossable lesions. What should we do? Through a stent struts, what should we do? When should we use a rota stiff wire, a non-TPI rotablator, and use of a large size burr? So here's a 72-year-old male patient, post-CABG, angina on exertion, NYHA class 2, occluded vein grafts to RCA, occluded vein grafts to OM, patent lima to LAD. And you can see here's a dual injection shot with an XP RCA and a lima shot, and you can see a dominant RCA filling distally. So we've crossed it with a Gaia 3 wire. I'm not going to go into detail, but this is what I want to share with you. And then we are trying to cross with the smallest balloon with an AL1 guiding catheter, but we are not able to cross with the balloon. So this is a lesion where it's not crossable with the balloon, and then we tried crossing with a fine cross. So even the fine cross is not crossable. So what do you do for such patients? How do you do a rotablator? You jam the fine cross to the distal, to the maximum point where it can go, and use a direct rota wire. So here you can see the fine cross is jammed inside the lesion and a small bend at the tip. If you give a big bend, it's not going to go. Sometimes I don't even give a bend at the tip, and you just advance the rota wire because it can go through it. And with that, a direct rota wire is done. And if the fine cross does not crosses, the burr is 1.25. It is standard. If your fine cross does not cross, you don't use a 1.5 burr. It is not going to go. If the fine cross crosses, it is 1.5. Otherwise, it is a 1.25 burr. A 1.25 burr was done in this patient, and this is the final angiogram with 2 stents in the dominant RCA. So for a non-crossable lesion, if does not cross with the balloon, does not cross with the fine cross, jam the fine cross, use the direct rota wire with a very small bend at the tip. Now here's an example of a 72-year-old male patient, and we are discussing burr not crossing. What do you do? Angina on exertion, 6 months, despite maximal medical therapy, present with non-STEMI, COPD, non-diabetic patients.
So you can see the angiogram, the RC was normal, approximal LED, 50 to 60% lesion, calcified lesion in the mid LED, Medina 111, calcified subtotal occlusion, and you can see a large diagonal coming. Again, the same thing happened, the wire crossed, I have to remove those pictures, but the balloon never crossed, and the fine cross also does not cross. So what do? You jam the fine cross and advance a direct rotawire. So you can see how you make a very small bend, and then you get the tactile feedback. So make sure you don't dissect the lesion. That's very important. You get the tactile feedback from this lesion, and then you see how the wire crosses. But I've made a very rough diagram because you need to understand. You need to understand how the lesion looks like. You can see this lesion actually has a calcified boulder, and I can identify a very small channel. So what happens now, because of this calcium, the rotawire could not be negotiated, and the rotawire gets trapped in the calcium. Can you do a burring at this point? What do you do? Because you end up wasting a lot of time advancing it, and then you get tired. But you cannot do burring on the black portion. But what we do in such situations is you come up with a 1.25 burr, and while burring, you press on the knob, and the second operator can advance the rotawire. Here you can clearly see, because when you start burring, the rotawire gets free from that trap of calcium. And then this is a 1.25 burr, and we burred for, as long as we got tired, but burr could not cross. What are the strategies? You increase the speed. My average speed is, I'm going to discuss that also, is just 150 to 155,000. Slower the speed, lesser the slow flow, and increase the more the luminal grain. So we increase the speed. You can use a guide liner for a 1.25 burr. You can use a rota stiff-fire, or sometimes we do a half rota. You just go as far as it goes, the rota comes out, take an NC balloon, and that is exactly what we did, but the balloon still did not cross. So we decided to wire the diagonal just because now the angulation and of the rota burring will be changed. So again, the fine cross does not go, but here is a direct rota wire. The reason we are doing is this is a mid LED. If this was a ostial LED or a left main or a proximal LED, you can send for cabbage. But here's a mid LED lesion, and we are advancing the rota wire with a small bend, and we hope that it will change the orientation of the burring, and this is what it did. So this is a 1.2, and the reason we have selected the diagonal, if you look at the angiogram, this is a good size diagonal, which is equivalent to the size of the LED. So we are burring with a 1.25 burr. Again, my speed is very slow. I don't try to jam the lesion. You do pecking movement, touch and come back and let it burr. And here you can see how the 1.25 burr crossed into the diagonal. And then this is the picture, do a pre-dilatation and then wire the LED. And then we wired the LED again with the rotablator wire. And now the rota burr. And then we burred with a 1.25 burr into the LED as well. So, and then just one stent. So important message from this case is, if the burr does not go, you can change the orientation of the burr. The way to change the orientation of this burr, sometimes you can change the guide itself. And if you are dealing with a proximal lesion, the guide also helps in changing the orientation of the burr. Do not use a stiff wire for such cases because there is more guttering and more wire burst. Can we do a rotablator for an ISR? We have to be very careful. Here's an example of a left main ISR. Post-cabbage patient, 90% stenosis, 111 lesion, LED ostal, 90% heavy calcium, KME1 flow. And the only lima to LED is patent, and you can see the lima to LED goes to the very distal portion of the LED segment. RC is a non-dominant vessel. So first is again a 1.75 burr for the left main, this left main. How do you select the burr size? 0.5 is to 1. So if your vessel is, let us say 4 mm, somewhere around 1.75 to 2. A smaller burr than that will not make a difference. So 1.75 burr for the distal left main circumflex. So I'm going to pause here. How do you do an ostial circumflex rotablator? That's very important. Sometimes we are scared that when you do an ostial circumflex rotablator, you're going to create a guttering. So what I do, others can correct me. What I do, I would engage my guide nicely and lift the wire from the outer curve of the circumflex. So you can see my guide position. If my guide is lifted like this, I'm going to gutter and cut. But if my guide is nicely seated from the root of the aorta into the left main,
and then it is going to come right in the middle of the circumflex or on the outer curve of the circumflex. And that is what you do. Again, this is not, we are discussing a 4.5 NC balloon. How do you wire the LED? You select a wire, guide to wire because of that stiff portion, and then a rota wire into the LED. Can you do a rotablator through the stent strut? Yes, but be very careful. You don't have to jam it in. You come back to the guide, go into the stent strut, come back into the guide, and go into the stent strut. This was an ISR of a stent which was placed 3 years ago. It's not a fresh stent, and this is how it goes. So take all your time. I don't increase my speed more than 1,55,000, and then this is standard. There's a 1.5 bar is not crossing. So you see, we use a 1.25 bar, that is also not crossing. Now here is a situation where we would encounter in our practice also a very tough lesion. You don't want to remove the rota wire. What you do is you do a parallel fielder wire and use a 1.5 balloon. Do a balloon dilatation. You can still do a rotablator after a balloon dilatation because your rota wire is still in the true lumen. And this is what we did. We did a parallel wiring, did a 1.5 10 mm balloon, and then a 2.0 balloon parallel, and the rota was reintroduced, a 1.75 bar, nicely done. And again, we're not discussing the stenting strategies, but a left main circumflex bifurcation stent was placed. And you can see a TIMI-3 flow in the distillation. So we also learned how to do burring if the fine cross does not process. Can we use a large size burr? Here's an example of a 2.0 burr. Again, you choose your patient very carefully because safety is very important. Here's an 81-year-old female patient, post-COVID, non-diabetic, frail, presented with ACS and unstable angina. You need to do an 8 mm burr for this, 8 French guide. And then IVUS was done. Again, we'll discuss this also, but you can see a nicely circumferential calcification which is present in the ostial eddy, proximal eddy, distal left main, point of confluence. A microcatheter was done, and then we used a 2.0 bar rota probe. For some reason this is not staying, but let me play on this. So how do you use a larger burr? Again, a very short rota run. That is very important. When you're using a larger burr, suppose you want to do a mid-LED lesion with a 1.75 burr, you don't start doing a rotablator from the ostial left main or ostial eddy. Go on a dyna, go up till the middle, very close to the lesion, remove the tension, and just do short burring. So this is a 2.0 burr inside an 8 French guide, and just a short burring runs just for the ostial eddy. And again, this is an octogenarian lady post-COVID, and you can see mitral annular calcium, and she's a high-risk patient for a surgery. And then definitely you need to optimize because you don't want these patients to come back with a stent thrombosis, and you try to do your best to prevent ISR. So the side branches, in elderly patients who are high risk for bleeding, my approach always is provisional. I don't like to put 2 stents because that increases the risk of restenosis as well as stent thrombosis. So just single DES was deployed from ostial left main to the proximal part of the LAD. And then a proximal optimization was done, and this is the IVUS where you can see the minimal luminal areas. We'll also discuss what is the optimal minimal luminal areas for proximal AD, proximal circumflex, point of confluence, left main, and a non-proximal vessels post-procedure which decreases the MACE outcome. So this is the final result, and you can see one stent from left main to LED for an octogenarian patient with limited mobility and TIMI-3 flow in all vessels. And this is the final IVUS outcome and the final angiogram. I'm also going to share our rota out. We are collecting all data. Up till now, I've completed 246 rotablators here. Hypertensive 168, diabetes also 168, CKD 10 patients. 10 patients has an EF of less than 35%. 63 cases were transradial. 34% patients were transfemoral. Left main 46, LAD LCX 122, RCA was 64. Average stent diameter is 3.2. Average birth size is 1.5. Imaging was done in 58 cases. Our outcome slow flow is 4,
no flow is 1. We had 0 emergency cabbage. We had 0 perforations. Our procedural mortality is 0 as of now. Impella support was done in 6 cases. IABP support was done in 8 cases. And ECMO plus IABP was used in 1 patient. This is our ROTA cases for last month, for 2021 till date. We're doing almost 6, 9, 12, 5, 4. These are our ROTA latest number for every month. My take-home message, I use generous intracoronary verapamil and adenosine. My speed is 1,50,000 to 1,55,000. Don't increase the speed for more than that because that is with slow flow. Burr run for us does not exceed more than 10 seconds. We would wait after 10 seconds, though the recommendation is up till 20 seconds. We would wait after 10 seconds, let the artery breathe. Keep the systolic blood pressure always above 100. We haven't used any temporary pacemaker in all our rotablator cases. And that is, we are going to try to publish this. We use aminophylline bolus before starting a rotablator. So no temporary pacemaker for these patients. Thank you very much for your kind attention.
Really, those were some great cases. And I really love the presentation of your own data. I think it makes it very clear how expert you are in the management of these types of patients. Have you ever had a burn not cross?
Today was the case. No,
Right?
I showed that case. So, we have done a few cases of half rotablator where the bud does not cross, but you don't try to jam it in. Just take a balloon because by this time the lesion has softened. But this one particular case is, I just wanted to highlight the reason why bud is not crossing. Sometimes it could be a wire bias. So change the orientation and angle, and that can help.
I think the only thing I might add to that, which you mentioned with your guide movement, is rotablations along wire bias lines, right? So after I'm through a lesion, I will try to rotablate the roof and the floor and both sides. So the guide gets pushed in a little bit, the wire goes up to the greater curvature, and you'll find that even though you've released resistance and your burr will go easily, once you move the guide, you'll get that resistance again. Then you pull the guide back a little bit and you do the floor. You turn it left, turn it right. So you really ensure that you're going to get cracks on all sides. Most of the time when that's been achieved, you can pre-dilate with just a simple non-compliant balloon because you've created multiple cracks on multiple sides.
The other thing which I want to highlight is the next pre-dilatation balloon is at least 1:1 or a 0.75:1, not smaller than this, and it should be an NC balloon. A smaller balloon can fool us.
Absolutely. And second, what's the dose of aminophylline that you use?
I asked my nursing staff to give 1 full ampule. How much is there in a 1 ampule? We have our nursing
50?
staff there.
Do you use 50? Is that we have?
I have 50. Well, we want to publish this and we're going to start writing all aminophylline. So how much is there in 1 aminophylline ampule? Our nursing staff is there. Mahesh, कितना होता है aminophylline के ampule में? ये भी नहीं पता.
I think, yeah, so I'm interested in because there's a lot of talk about it preventing.
Aminophylline? What is the role of aminophylline?
So, one of the reasons for slow flow is adenosine mediated.
That's right.
So you give aminophylline up front, and we haven't noticed any CHPs.
We have also not used temporary pacemaker in any case. We are not using.
But yeah, so the aminophylline is for the prevention of rota-induced bradycardia,
Yes.
as opposed to slow flow. There's a slight difference there, and that's important, right? That's why I think he goes after no pacemakers.
So, and how much are we giving? So we're giving 10 ml of aminophylline, that is almost 250 milligrams.
250 milligrams, okay. And that's into a bag of normal saline? No, that's probably into your saline solution, right, on your rotablator, or you're giving it actually to the patient?
The way to assess the effect is you will notice tachycardia starts happening.
Yeah. So like we do that, but we actually put the aminophylline into the saline bag or into the rotaglide bag so that it's constantly going into the patient when we're doing the rotablation.
How many in the audience, or maybe you can comment, have noticed a temporary pacemaker-induced RV perforation for an elective rota case?
Sucks. Horrible. Horrible. Right? So I
So
never put
inferior
pacemakers
wall MIs
in.
we all noticed, but for an elective rota case, a temporary pacemaker-induced perforation?
I've seen these. I have seen them. Right? It's terrible. Which is why I don't put pacemakers in either unless the patient cannot tolerate asystole for 5 seconds, right? Like these EFs of 20%, sure, I'll put them in just because you have no reserve. But other than that, almost never.
You have discussed the complexities of the road ablation. Did you encounter at any point of time, or even if you have not encountered, what are the strategies you would like to use if the burr gets stuck?
So,
Just doesn't come out.
So one is we should analyze the angiogram upfront, and you should be able to understand whether the burr will get stuck or not. So I'm going to share one case where I was talking to all my colleagues that this burr is going to get stuck, and that was a mid RCA ISR at a bend, and we were talking it, and the burr got stuck. And one more reason why the burr gets stuck is if you're trying to jam it in and you are in a hurry to ablate, so the tip goes, but the back end does not come back. So what we did is we cut the catheter, went with a guide liner, and then just yanked it out. But multiple things, you can put a wire, put a balloon, put a rota wire, use a 1.25 rota, and ablate that calcium and remove the second rota burr. But what we did is we got lucky, we cut it, advanced the guide liner till the mouth of the rota burr, and then just removed it. And it was an RCA. But I would say, sir, it's better to anticipate such complications and prevent it rather than to have it in the LAD. Yes.
I think beautiful presentation, Ravinder. Shall we go for the next? Two more cases here. The next case by Dr. Nikhil Chaudhary.
So good evening, everyone. Thank you, Ravinder, for the invite. And so we have had a lot of learning today about rotablation. So I'm just presenting one case where I think a lot of things which we discussed today, I'll be able to throw some light again on those things. So my patient is a 70-year-old gentleman who had underwent a proximal RCA and LCX PCI in 2013. He had an ISR for 2018. He again had underwent a PTCA to the proximal and mid RCA with 2 stents. So both of them were at a different center. And he presented to me, presented to the same center actually with unstable angina for last 6 months. And ECG was more or less showing some Q waves in inferior leads with a hypokinetic RCA territory and ejection fraction of 45%. So this was the diagnostic coronary angiogram done outside. Of course, you can appreciate the heavily calcific LAD and LCX. So definitely, left main distal left main is around 80% calcific lesion, and LAD again is a diffusely diseased vessel. A lot of calcium, and another thing which was striking here is the lot of tortuosity in the proximal to mid LAD. So the iliocranial view looks really bad. What was actually confusing to me was what is happening here at the distal left main, at the crux of the LAD and LCX. Maybe some aneurysm. This is what his right coronary system looked like. So he had 3 stents in the RCA, 1 in the proximal and 2 in the mid. And at the distal stent edge of the mid to distal RCA, there was a type 95% stenosis. So here plan of management were syntax score of 36. Patient was offered CABG, but he refused. So PTCA, again, of course, he needs intervention. But what things which came into my mind were RCA, do I need to rotablate? LAD left system is heavily calcified. Do I need to do calcium modification for the right system as well? Again, he already has 3 stents there. Do I put another stent after doing plaque modification? So maybe I said, let me decide after imaging. For his left system, the questions in my mind were with the aneurysmal distal left main, what exactly is happening there. Calcium modification, again, of course, rotablation looked necessary here. Challenges for me here were, if you look at the upper picture, the bend between the left main and the LED, around a 90 or more than 90 degrees bend. A tortuous mid LED segment, and the choice of the burr, should I start with 1.5 or 1.25? So I started with the RCA PCI. So of course my plan was to do the IVUS first, and after doing the initial IVUS, the pre-IVUS, I could see there was not a lot of calcium, maybe just a 90-degree calcium in the mid to distal portion of the RCA. It was more of a fibrotic lesion, mid RCA MLA of 2, and of course the reason for ISR here was an underexpanded stent, which the IVUS gave me a clearer picture. So pre-dilated with a 2 and a 2 balloon. However, when I wanted to cross the 2.5 balloon, the guide would not support, so exchange the guide to an XBRCA. It almost always helps. XBRCA, excellent guide for such lesions. Then again, I was able to cross with the 2.5, did a scoring balloon with the angiosculp, and then at very aggressive post dilatation with a 3.5 NC tract. Finally deployed a Synergy 3.548 in the mid to distal RCA. Did an IVUS again, showing good expansion of the stent. 3 layers of the stent can also be appreciated. So nowadays with IVUS, very clear imaging and very clear pictures are available. So this was the final RCA result. So after this, moved on to the left system, and hooked with a EBU's 3.57 French guide, and looking at this picture, I thought whether I should leave it for another day. Looks really bad and really ugly. Anyway, decided to proceed. So wired. So this is my choice of wiring. Usually with a rotawire is I usually start with a BMW or a Whisper, and along with that simultaneously I cross the rotawire. So in this case also I was able to cross the rota through this similar picture. Of course, when it doesn't cross, then one can use a microcatheter and do it. But most of the time parallel wiring works for me. Then decide to image it, but the IVUS would not cross beyond the proximal LED. So just to look at the proximal LED and the left vein, did a pullback here. Sorry, not running for some reason. So for this case, actually, I was worried of all the complications which can happen in a rota, and so you should anticipate them well in advance to avoid them. So stuck burr, perforation, all these can happen. So the strategy here for me was to burr very short segments. So I parked the 1.5 mm burr in the left main. And just try to, I use more of a cruising motion rather than a pecking motion, and used a burring speed of 1,60,000 RPM, and cross the distal left main lesion. Then again tried to cross the proximal LED, but I could not do that. So basically what I did here was change my view. It gives you a better alignment. Change it to a cranial view and increase my burr speed to 1,80,000, and with that I could cross the burr. Then ablated the whole segment. I did lot of ablation here. So of course the idea is to do short segment of ablation and for short durations. For this patient, actually, I had to, the total duration was around 90 seconds of burring because of all the tortuosity and bends. So this was the result after rotablation, and did an IVUS here. Sorry, the IVUS video is not playing. But then after doing the rota, and I started pre-dilating with a 2.5 mm balloon. Had some difficulty in balloon crossing, and did a cutting balloon. Landed up with no reflow after pre-dilatation. Managed that with all the things which we have discussed. Another thing I'd like to point is, again, we don't use a TPI. Most of the times, 99% of the times, you won't have anything other than a transient CHB. So this was the result after pre-dilatation. It's not running here. So again, here I was concerned whether my stent would be able to cross. I had dissected whole of the LAD, but thankfully with the Synergy platform, you can see how easily the stent could cross. Of course, the bed preparation is must. You need to make a good bed. So then with the, after the mid LAD, then left main to proximal LAD. Synergy stent, did a pot, followed by post dilatation. There was a part in the mid LAD which had a calcific nodule, and which even with aggressive post dilatation, I was not able to do that. I didn't have an OP and NC here on table, but the MLA here was around 9, so accepted that, and this was the final result. Thank you, everyone.
Nikhil, nice presentation. Beautiful. So, any question from the audience?
Questions?
Thank you.
Thank you. Thank
Great
you.
case. Thank you.
Yeah. Now the last case by Dr. Devendra Kumar.
So, good evening, chairpersons or my friends. This is last presentation, and I think this is very informative also. So, we all know that when we are doing rotablation, I always keep three important things in my mind. First and foremost, which is usually seen often, is slow flow and no flow. Second one is like if you are doing rotablation, perforation is one important. And whenever you are doing rotablation, always keep in mind that the stent graft or covered stent should be in your cath lab, otherwise you should not do rotablation. And third one is stuck rotabler, which is life-threatening condition. If suppose it happens in a normal flowing artery, you are just doing iatrogenic myocardial infarction in that patient. So we should always keep in mind that how we should tackle these things. So in my case, this is a case of entrapment of rotablation bar. Excuse me, slides are not running. Sorry. So this was a 63-year male patient having a follow-up case of lateral wall MI in 2018. His angiogram was done, which was showing triple vessel disease with primary post-primary PCI2 L6 was done elsewhere with the 2.5/38 mm drug-eluting stent. He had angiogram in which diagonal was having mid 90% stenosis and RCA was having calcified lesion. So we planned for rotablation in this case, and we used right and left femoral arteries, that one I will explain, and catheter was GR guiding catheter, then AL1 guiding catheter, and filter FC and BMW were apart from the rota. So this was, in this case, we used 1.5 mm bar. So this was the angiogram, still picture. I will go rapidly, showing that the L6 stent was patent. Diagonal was having like 90% lesion. Then this was the RCA, which we can see in one window that was heavily calcified and very tight stenosis was there. And it was diseased from proximal to distal part. So you can see here, like starting with the rotablation, I used 1.5 mm bar, and speed was around like 150, 160, and I was able to, we can see here that how calcified lesion was there. In mid RCA it was like giving way, and we used rota floppy wire. After doing rotablation, we checked the proximal part because we have not reached till the last part of RCA. We can see here that everything was okay. Later part, the distalmost part was again here. We can see it was not ablated till now, this last part. So when I pushed the rota bar and started worrying this, suddenly I felt that the rota bar is stuck in the distalmost part of the RCA. Not only this, because of this, when it stuck at the distal part of the RCA, patient suddenly started having hypotension and bradycardia. As I told you, it is just like creating iatrogenic myocardial infarction. Immediately, patient had the ST elevation and started having ventricular fibrillation. And during that time, we give DC shock at least 6 times because patient was having like recurrent ventricular fibrillation. I usually prefer to put TPI in, particularly in RCA rotablation, and because TPI was in situ. We started inotrops also, but important thing is that even after putting the TPI or inotropic support, if you don't establish the flow, it is of no use. Even if you are giving adrenaline, noradrenaline, whatever you do, atropine, but if the flow is not established, these all things are futile. They will not work. So in such cases, what I did, I took another catheter, try to pass the wire. As we know that there are certain strategies in which one thing is that you could pass the wire across the, means taking the second guiding catheter from the opposite side, pass the wire, try to dilate it with the smallest balloon, like even 1.5, 1.25, 1 or even 1.5 balloon. So you will get some space so that your stuck rotabar can come out. And if it doesn't work, then second option, I will discuss all these things in a slight manner. So I tried first the wire, but wire was not crossing. I took filter FC wire, it was not crossing. Even I took harder wire, like I took in this case CrossFit wire, but it was not crossing at all. By that time, because patient was already having intermittent ventricular fibrillation, so in that condition, I straightforward cut the wire from the, I detached this part of the rotabar, cut the sheath, outer sheath of this rota, over which this rotavar goes, take out. So now the wire of your wire is free, and over that wire you can push anything, like you can push the balloon there, and can put the balloon at the distalmost part where the bar is stuck, and then you can apply the force, because by doing this you are directly transmitting your force at the bar tip, so the force will be directly transmitted. Second thing, if you try without like cutting the sheath and all these things, when you pull, you try to pull the bar, what will happen, your guide will deeply engage and can cause perforation or dissection. So these things are important. So in this condition, luckily, I was able, after cutting the sheath or taking out the sheath, when I took it, the bar came out. Other things which we can do is like passing the snare till the distal most part and catching the wire from the distal most part. And third thing is like guide liner and anything can be passed over the wire, because now you are free. Your wire is support anything because your guide, and there is space in between your guide and the wire. So this is one technique we did in catalog. We take out the sheath over the wire and directly just giving gentle traction, it came out. Otherwise we could use snare also, or guide liner also, or even small balloon, and then can apply force. And the last one is, if you are not able to do this thing, then surgery is the final option. But even in such conditions, sometimes patient doesn't give you time. So like if we go step by step, or what recommendations are there if there is a stuck bar in or beyond the stenosis, which is known as Cauchy phenomena. So first thing is like you can put like here, second guide wire can be pushed, after which you can pass the wire, can dilate the side space and can release it. Second one is like disassembling the rota system, remove external rota sheath, and cut the bar just distal to the rota connector. Advance, feed the guide extension catheter over the shaft of the, as I told you, and trap with balloon and pull. Second guide wire balloon can be passed and can try to take it out. Third option is surgery, which is like in many of the cases we are not able to shift the patient to the OT. Then another one is like snare can be used. Then mini star technique, only if you are doing the CTO procedure, then you can do subintimal tracking and taking out the wire and then can dilate it. That is another possibility, and we cannot recommend conservative approach in this condition. So this is the slide and how these methods can help you in such nightmares. So finally, I was able to take out it, dilated further, and took another support wire so that I can put balloon, and I dilated with angioscalp, because in calcified lesion it is always necessary to pre-dilate, prepare the bed properly. And putting the I'm rapidly going for final. was the final picture in this case. It came out successfully. So this was the final picture, and luckily we could successfully do this case. So somebody like we were discussing about rota not burying. So there is one more case here if you have time. Just few slides. So like I'm rapidly going, not trying the other thing. This is the artery again. So in this when we were doing rota ablation diffuse disease, distally it was good artery having large size of PGA and PLV, which we thought that we should open this artery and so different views. You can see calcium. So we started with procedure temporary pacemaker. I used prophylactically. RC it was diffusely diseased and calcified. After passing the wire, we started doing rota. Initially started with 1.5 mm, but at particular point, if you can see here that the rota was not crossing at all. I was little bit vigorous in this case, which one should not. I changed to 1.25 mm bar also, but it was not crossing. So because I saw that we have created proximal dissection also at this point, so at this particular point the rota was stucking. So possibly the wire bias. We tried it hard also. You can see here the how, but when it was not crossing, what next? We took a small balloon and we tried so many times, but it was not crossing. Finally, smallest balloon was taken, and fortunately here it was not crossing. Again, means repeated episodes like tried balloon, tried first rota ablation. You can see here that rota ablation was tried before this. Then I tried the balloon also. It was not crossing. Then again I tried here. It was not crossing. Then again tried rota ablation also. Then at this time the balloon was able to cross. So at this particular point here, we can say that it was not crossing. So after when it was not crossing, we took the smallest balloon which could cross. We dilated it further, and then the procedure was completed successfully. This was the final picture of RCA after doing angioplasty.
Nice presentation. Yeah, even the excellent case.
No, excellent cases.
I think Dr. Devendra, these two cases are very excellent, and you successfully de-entrapped the entrapped burr, and secondly, finally you crossed the non-crossable rota. I request Ravinder, I think he can give the final concluding remark.
First and foremost, thank you very much to all the audience who could spend time on this evening for this academic session. But I would like to thank all the chairpersons from my bottom of my heart, sir, for staying all throughout the program and making it a success, and we could share and learn from you. And I would also like to thank Dr. Sanjog Kalra for spending the evening with us. But before you guys leave, we have a small token of appreciation and felicitation. I would like to call upon Dr. Sanjog Kalra and all our chairpersons. And a token of appreciation for all our chairpersons, Dr. G.L. Sharma, sir. And the speakers who are there in the audience, Devendra Shimal sir and Nikhil, where are you? Come. Devendra Shimal. And thank you all the presenters also. And thank you Boston Scientific for making this program a success.
Finally, we must thankful to Dr. Ravinder Rao and for this successful and grand academic fest. We have to present the bouquet, Dr. Chanwani.